Our final lecture of today is on syncope by Vishal Goyal. Vishal's one of our new associates, and we're very pleased to have him working with us here in Santa Rosa. Vishal received his MD degree from St. Louis University, and then went on to do a internal medicine residency at UC Davis, and then cardiology fellowship at the University of New Mexico in Albuquerque, where he finished up as the chief cardiac fellow. We're very happy to have him here, and we're looking forward to his talk today. Vishal?
Thanks, Tom. I was hoping everybody could look at this picture. I think you have a full-blown black and white in your syllabus and come up with a story of what you think happened here as we go through this talk, and we'll come back to it, and I'd be happy to entertain any people's ideas as to what happened. It's kind of interesting. Just out of curiosity, since we polled the audience earlier and it hasn't happened again, has anyone had syncope before? Anybody get a clear diagnosis? Not a single one. Interesting. Anybody feel dizzy or lightheaded when they stood up after lunch in the sun or on the tables here? Quite a few. And that's with a pitcher of water for every two of us. So this is certainly something that we see a lot, and it's certainly something that's common in our patients, whether it's frank syncope or dizziness on standing. And so my goal of this talk is really hopefully to make you more comfortable with managing syncope and when to refer syncope patients. I don't know that I'll be able to help you too much in the diagnosis of it, as we just saw about 0 out of 30 ever got a diagnosis. Syncope is certainly a very common problem. The point of this talk, try to determine if the patient's at increased risk for death, improve their quality of life, prevent injury to the patient and others. And as you'll see, diagnosis is not part of the point of this talk. It's really hard to do. Objectives. Tell you about the definition of syncope. That's first and foremost what you need to do is say, is this really syncope? Talk about the different classifications of syncope, how to evaluate it, a little bit about maybe how to diagnose it and what the management is. I'd like to start off with a case study. 43-year-old male who was referred to me for hypotension and syncope, long history of recurrent episodes, multiple injuries to a shoulder, to a finger, to his teeth, multiple events over many years. Events are sometimes preceded by a prodrome of lightheadedness. He's never had chest pain or palpitations. Events usually occur after standing from a laying position, but have also occurred in the shower. His blood pressure at home has been recorded as low as 70/70, so you're automatically questioning everything else that he's told you, because his blood pressure is always 70. And he spends most of the time on his parents' couch because he's afraid to do anything that gets him out of the house because he's worried about injuring himself, and that's really the most worrisome part of his entire history. You need to be able to ask a lot of questions. We have a lot of tests in cardiology, but it's your history and your exam that's going to be the most sensitive and the most specific test to figure out what is going on with this patient. And this is a list of questions that should be asked of anybody that you're evaluating for syncope. Was there a complete loss of consciousness? Was it short in duration, rapid in onset? And was there a spontaneous complete recovery? Was there a loss of postural tone? I had a patient who was referred to me for syncope while climbing stairs. My first question was, well, did you fall down the stairs? And she said, no, my husband found me on the middle of the stairs, helped me back up to the top of the stairs. And I said, well, it's really darn difficult to syncope in the middle of the stairs without falling down and hurting yourself, because there should be an associated loss of postural tone. You also want to know what the precipitating factors are. What's the body position, activity prior to and after the event? Were there any prodromal or recovery symptoms? I had a lady sent to me who syncopized or had a loss of consciousness at a basketball game. She had been watching a high school game, had been sitting down for about 45 minutes. Her, I think, sister noted her to lose consciousness for about a minute, and she was sent to me for evaluation. Highly unlikely to be arrhythmogenic when she had been sitting for a long period of time, and didn't have any prodrome and was easily aroused by her sister. Maybe she fell asleep. Maybe it was a boring basketball game. I don't know. But it's not likely to be cardiac or arrhythmogenic syncope, and we'll get into the why of that in a little bit. You want to know if there are any witnesses. Can anybody describe the fall? Almost all syncope is associated with some degree of amnesia, so your patient is always your worst historian. They're always going to say they can't remember if they had a prodrome prior to the event. So if there's someone around them that could tell you what happened, that is extremely helpful. I had a patient who was sent to me for syncope. He actually ended up in the hospital. He worked as a pilot car operator for a house-moving company. So he's in that car that goes ahead of the big house on the road, and his thing says oversized load in case you couldn't see it behind him, occupying 3 lanes on the freeway. And he was sold to me as someone who had lost consciousness and ran off the road. Didn't injure himself, didn't really injure his car, ended up in a ditch. My first question was, well, what did the guy behind you see? And the guy behind him said, well, he sort of veered to the left and then he corrected to the right, and then he was going to the right and then corrected to the left, and then all of a sudden he overcorrected and ended up in the ditch. That doesn't sound to me like he lost consciousness. He was making purposeful maneuvers. And that's a very helpful history, and that will save you a lot of time, trouble, and diagnostic studies if you can elicit that history. Description of the fall, patient skin color and breathing, those can help you discriminate sometimes seizure disorders from true syncope. Any movements during unconsciousness can sometimes help, although you can have movements during unconsciousness in multiple forms of syncope. But another example is a patient who is about 30 years old, works as a waiter, and was carrying a tray at work in the kitchen and just went down. All of a sudden just went down, witnessed by everyone in the kitchen, clattering tray, corroborated by a lot of people. And I'm much more interested. That sounds like real syncope. Turns out he was started on a beta blocker 2 weeks prior to that, had stopped the beta blocker, was seeing me 2 months later, had no more recurrences of anything. That's real cardiac syncope, likely iatrogenic due to his beta blocker. Prior events also are very important, as you'll see later in an algorithmic approach to syncope. Other questions that I like to ask: any personal history of cardiac or metabolic disease. This may just change your pretest probability for syncope or other causes of syncope. Any family history of sudden cardiac death or syncope. And then, of course, medications, as I just alluded to, are always very important to know what they're on, why they're on it, and was anything recently changed. So, is it syncope? This is the definition of syncope. Syncope is a transient loss of consciousness due to transient global cerebral hypoperfusion, rapid in onset, short in duration, and associated with spontaneous recovery that does not require electrical or chemical therapy for reversal. And you need to meet all of these criteria for it to be syncope. Very important. Going back to our guy who's sleeping on his parents' couch with a blood pressure of 70, syncopal episodes last 20 to 60 seconds. He always has a spontaneous return to alert consciousness. So if we're believing his story, this is worrisome. He's injured himself, he's had recurrent episodes, they're transient, he doesn't get any warning, and he is clearly having an impact on his lifestyle because he can't get off the couch. Another detour. On my exam, my goals are to determine his level of hydration, any presence of structural heart disease, and any neurologic abnormalities. This is something that we should do on most patients, but certainly patients with syncope. Again, very important, trying to determine the cause. If you're going to do orthostatic vital signs, probably worth doing them correctly. It's a pain in the butt. I think all of my MAs hate me, but this is how I do it. Heart rate and blood pressure supine every minute while standing for at least 3 minutes. You can be orthostatic at minute 1 and not minute 3. You can be orthostatic at minute 3 and not minute 1. So it's important to serially do orthostatic vital signs. Early orthostatic hypotension is defined as a drop in systolic pressure of at least 20 millimeters mercury, or a drop in diastolic blood pressure 10 millimeters mercury. This will also help you screen for POTS, postural orthostatic tachycardia syndrome, which is a symptomatic increase in heart rate of 28 beats per minute or more. Symptomatic, also a key word here. You can be orthostatic and hypotensive, but asymptomatic, and then you have a lot of trouble saying, well, is that what caused their syncope? Symptomatic is key. So you want to know, are you dizzy? Every time you check the vital signs doing orthostatics, are you dizzy? Are you feeling lightheaded? Carotid sinus pressure is something that most cardiologists do, and I encourage most primary care docs and ER docs to do this also. There are some patients that you do not want to do this in. If they're younger than 30, or if they have a carotid bruit or a history of a stroke, you may want to be careful doing this unless significant carotid disease has already been excluded by a duplex. And I gotta say, anyone who's ever had a stroke has had a duplex, so you should probably know. If they don't meet those criteria, go ahead and do carotid sinus pressure, and I do this, again, not carotid sinus massage, but carotid sinus pressure. Gentle pressure over the carotid pulsation just below the angle of the jaw, right up in here, where you expect the carotid artery to be bifurcating. That's where the baroreceptors are. The textbook would suggest you should do this while supine and upright. I think that's a little redundant. I do it in one position or the other, wherever I find my patient. And I apply pressure gently for 5 to 10 seconds, and I'm looking at the monitor, I'm looking at the patient, and I'm feeling their pulse, usually also in their wrist, and trying to determine, was there a 3-second pause? Did they just lose consciousness on me? Or something like that, which would be notable. A normal response, transient decrease in heart rate. A lot of people go from 80 to 70, maybe 80 to 60. It'll be very short-lived as long as you're holding pressure. Transient delay in AV conduction, also normal. Abnormal, on the other hand, is broken up into 2 categories. Cardioinhibitory, which is a decrease in heart rate or sinus pause greater than 3 seconds. It's important to discriminate cardioinhibitory as a response because, as you'll see later, that may give them an indication for a pacemaker, versus vasodepressive, which is a large drop in systolic blood pressure. That's something that's not likely to respond to a pacemaker, but it may be diagnostic as their cause of syncope, and we could talk about medical therapy for that. And again, it's important to note, are they symptomatic while you're doing this? Because they may have an abnormal response, but it's not diagnostic of the cause of their syncope unless it reproduces symptoms. So going back to our original patient, young 40s, recurrent episodes of syncope, low blood pressure. His medical history is notable for endocrinologic disease, diabetes, hypothyroid. He also has chronic eczema and asthma. And turns out that he took a lot of prednisone throughout his teenage years up until the age of 20 or 22 when someone noticed that he hadn't reached puberty yet. And they gave him testosterone, and all of a sudden he achieved puberty. His vital signs, he was clearly hypotensive, although notably not orthostatic. He was tachycardic, although his heart rate goes down when he stands up, so he does not have POTS. And the rest of his exam was unremarkable. Carotid sinus pressure was normal. So, does he have syncope? I think so. I think that's fair to say. It meets all my criteria. He has a loss of consciousness. It's transient, it's rapid in onset, short in duration. It's associated with spontaneous recovery. It's not related to trauma. So I think this is syncope. What kind of syncope is this? Well, he has orthostasis. He does not have orthostasis, but he is hypotensive, so it's not quite orthostatic hypotension. Maybe neurally mediated, but then I gave you some clues about these endocrine abnormalities, so perhaps it's non-syncopal syncope. Don't ask me. Call it transient loss of consciousness. The problem is we all call it syncope, and I'm a victim of that too. So, in fairness, it's transient loss of consciousness that's non-syncopal. Or maybe it bridges categories. We're going to take a little detour to talk about the kinds of neurally mediated syncope. This is the most common cause, reflex, also called neurally mediated syncope. In the literature, you'll see, I think, maybe about 5 different terms that all relates to the same diagnosis. And this is the most common etiology of reflex syncope. You'll see these stories of Royal Mounties or the British Royal Guard, and they fall with no warning whatsoever. And you would think that'd be arrhythmogenic because we've all been told in medical school, well, they had no warning, they just dropped, they injured their knees or their face. That's not always the case. This is reflex syncope. It can have a vasovagal component associated with emotion, anxiety, or pain. It can have a situational component associated with being in a medical setting or associated with cough, micturition, defecation. It can be related to postprandial hypoglycemia. Carotid sinus pressure, those are the people that have a tight neck collar, turn their head, and all of a sudden lose consciousness. Suggesting signs and symptoms, well, absence of structural heart disease, long history of recurrent syncope, prolonged standing or crowded hot places, those are your British Guards, nausea and vomiting, occurrence during or immediately after a meal, or as I mentioned, people with tight neck collar rotating their head and losing consciousness. I didn't want to go through this slide too much, but this is just to show you that it's complicated. People always say, why does this happen to me? And all I can answer is, it's complicated. You have brainstem issues, you have higher cortical issues, you have vagus nerve stimulation, and it's not well understood. I think the most interesting thing about this slide is noticing that people who see something and then fall in consciousness are clearly using higher cortical functions. So it's not all brainstem, it's not all what we think of as reflex syncope. There's other things going on. One proposed mechanism, and this is in the textbook, is you're already dealing with someone who has venous pooling, decreases their preload. We as cardiologists know that if you stand for a prolonged period of time, you can displace up to 10–15% of your blood volume in your legs and your abdomen, so you're clearly preload deficient. When you're preload deficient, the arterial baroreceptors in your neck sense the reduction in cardiac output and blood pressure and cause a tachycardic response mediated by catecholamines. Because your left ventricle is empty from the decreased preload, you're essentially flogging a dehydrated heart, and this causes a reflex to the medulla, which then increases vagal tone because your heart does not like being flogged, and that causes more vasodilatation and bradycardia, and then you lose consciousness. This is a proposed mechanism, and it's already complicated. I can't explain it any further. I don't want to go into the other proposed mechanisms. Okay, orthostatic hypotension, another common cause, but again, reflex syncope is the most common cause. Orthostatic hypotension can be due to autonomic nervous systems, primary autonomic nervous failure, such as in Parkinson's, or secondary autonomic failure, such as in diabetes, amyloid, or spinal cord injuries. Can also be iatrogenic. I like to think of drinking alcohol as iatrogenic. It's something we do to ourselves. Diuretics, vasodilators, hypovolemia due to hemorrhage, diarrhea, or vomiting. These all lead to hypovolemia, hypotension, and orthostasis. Suggesting signs and symptoms: syncope after standing, syncope after recent medication changes that cause vasodilatation or dehydration, syncope after prolonged standing. This is where it blends into the Royal Guards, where there can be a component of both. Syncope in the setting of Parkinson's, or standing after exertion, and that's a key point, is after exertion. Syncope during exertion, much more worrisome. Cardiac syncope, that's generally what you'll see. The guy just drops. No warning, sometimes maybe palpitations, not usually, but they drop and they hit their head, and they end up like this poor fellow. Cardiac syncope, what we're looking for are arrhythmias. This doesn't have to be VT, and most frequently it's not VT. It can be a bradyarrhythmia, it can be sick sinus syndrome, it can be AV block, it can be SVT. It can also be seen in the presence of structural heart disease, and that includes heart failure, that includes pulmonary hypertension, includes HOCM, aortic dissection, etc. Suggesting signs and symptoms of cardiac syncope, certainly anyone with known heart disease. Syncope in the setting of a family history, syncope while exerting yourself or while supine, syncope with palpitations, and any abnormal EKG. Turns out that any abnormality, if the computer says abnormal or you see an abnormality, automatically increases the chance of mortality in syncope. Now we have to take that with a grain of salt. Normal is obviously better, and minor abnormalities are not a big deal, but it's important, and this gets to one of my recommendations later about getting an EKG in every single patient with syncope. So back to our case study. The guy in his young 40s, endocrine abnormalities. He's hypotensive, but he's not orthostatic. It's hard to categorize him in a single place. Is it syncope or is it my non-syncopal syncope? Well, I knew I could make him better because I knew I could raise his blood pressure. I gave him midodrine, I gave him fludrocortisone, and I certainly did raise his blood pressure. I checked his cortisol and I checked his ACTH, and they were nearly undetectable. So I don't know his endocrinologic diagnosis. I would have to beg Dr. Nakai to educate me, but I know that it's not normal. And so I fixed his blood pressure, I got him to feel better, and I sent him to an endocrinologist. Okay, just to talk about the last couple of causes of loss of consciousness. Vertebral basilar insufficiency will usually be present with other neurologic findings. Migraine mediated, well, it should be associated with migraine symptoms. The seizure, you'll see seizure-like symptoms. And that's about it. So case study number 2, this one's also an interesting case. 29-year-old female, works for the US Air Force, very intelligent girl, very healthy girl, except that she loses consciousness almost every day. And she's an aircraft engineer, and they're going to terminate her contract because they don't think that she's safe at work. She hasn't injured herself, but they're worried about the quality of her work because she keeps losing consciousness. Her events usually are associated with a prodrome of dizziness and lightheadedness. I mentioned she's never injured herself. Episodes are very brief. Wakes up fully alert, knows that she's lost consciousness, and I mentioned how frequent they are. So it meets all my criteria for syncope. Complete loss of consciousness, rapid onset, shortened duration, complete spontaneous recovery. She has no family history of sudden cardiac death. She's not on any medications. She's not on any stimulants. And because she's in the U.S. Air Force, and I guess we paid for her workup, she's had a $1 million workup with negative MRIs, negative carotids, negative echo, negative stress testing in a 29-year-old female. But she has had a positive tilt table, and we'll talk about that a little bit later. And in fairness to the U.S. Air Force, we did previously recommend trials of beta blockers. We don't do that much anymore, but it didn't work for her. So just to detour a little bit about testing, because the Air Force gave me the in to do this. Routine testing of all the things they did are not indicated, and they're frequently not useful. Most cardiologists will not do EEGs, head CTs, checking enzymes, carotid imaging for syncope. However, an ECG should be performed in all patients because studies have shown that in 1 in 20 you'll get a diagnosis, and another 1 in 20 you'll have a suggestion of a diagnosis. Things that cardiologists look for, but that you may see also, arrhythmogenic right ventricular dysplasia with epsilon waves. I hope anybody can diagnose an acute MI, and of course advanced conduction disease. I had a patient who was consulted on in the emergency room who the consult was for syncope, and I asked him, have you ever lost consciousness? He said, no. And I said, great, we're done. And then he said, well, I enter a fugue-like state. I get into a dream state. I think I'm conscious, I'm not sure. And I go into my, oh my God, I need another witness mode because his history is useless. Total evaluation in the emergency room, normal. I said this was not a great consult. 4 days later, he's diagnosed with complete heart block. Never had syncope that I know of, but he had advanced conduction disease. So certainly these can overlap. Echo is probably the second most test that's frequently performed, whether by a cardiologist or requested by primary care physicians. It certainly should be performed in patients who are at risk for structural heart disease, elderly patients, abnormal EKG, family history of sudden cardiac death. Syncope of abrupt onset is iffy. This is where you use your judgment. I think that echo is great. It's non-invasive. I'm an echocardiographer, but I will tell you that echo is often non-diagnostic, and it's usually normal, especially in most first-time offenders with syncope. So even I don't order an echo in all of my syncope patients. I did promise we'd talk about tilt table testing, and here it is. It's mainly indicated to confirm an already suspected diagnosis of neurally mediated syncope, has no value in being repeated to determine the efficacy of your treatment. And one place where it might be interesting is your 20-year-old girl who you're thinking of conversion disorder, and you put her on the tilt table and she promptly loses consciousness and her vital signs are totally normal. And then you could say, well, I told you might be crazy. Why don't more cardiologists do tilt table testing? I haven't done one since I got out of fellowship. I hated doing them in fellowship, but at least I have a reason why. The sensitivity is 25 to 80%. That's pretty useless. It's almost a coin toss, plus or minus 30%. And if their evaluation is otherwise normal, and if you're already suspecting neurally mediated syncope, the tilt table does not change your post-test probability. If it's positive, great, you were already thinking reflex syncope. If it's negative, the chances of reflex syncope are so high that that's still your most likely diagnosis. Stress testing, it's not something that you'll see most cardiologists do in the workup of syncope, but it can be done if you have a high suspicion of ischemia causing syncope. It takes a whole lot of ischemia to cause enough global cerebral hypoperfusion that someone will lose consciousness, and your EKG will probably reflect that, at which point you don't need to stress test, you need to do something more definitive. But if you're going to do stress testing, it should be in a patient who had symptoms during or immediately after exertion, syncope associated with chest pain, or patients at high risk of coronary disease. There is some controversy among expert opinion in the patient who says, I always syncope when I'm at the gym, because that's again more likely due to vagal tone than it is due to exertion, but it's a case-by-case basis and reserved for independent judgment. Cardiologists, we may recommend cardiac cath, as I just mentioned. If you have a patient with a huge MI who lost consciousness, well, you want to treat their MI. That's why we're going to cath them. We may also recommend monitoring. In the inpatient world, this would be telemetry. In the outpatient world, this could be anything from a Holter to an event recorder to an implantable loop recorder. I think in the future, we may be doing implantable loop recorders a little bit more as they get better and they get easier to put in. There is actually some data that suggests the overall cost of a syncope workup is lower if every syncopal patient you just start with a loop recorder. You don't do an echo, you don't do Holter, you don't do an event recorder, you just put the loop recorder in and you're done. You wait for one more event and you have your diagnosis. I think that remains to be seen. And you may also see us recommending an EP study. And this is where we'll get Dr. Molden and say, I'm really, really worried about this guy. Sometimes we say, I can't tell you why, I just have a bad feeling. Sometimes we'll say, the guy's a commercial pilot and he can't go back to work unless we do this. Or you may hear us say he's had 20 syncopes, 20 broken bones, he's crashed his car 4 times, I think it's time to do an EP study. Usually that'll be after multiple non-diagnostic studies, but there are plenty of cases where you just have a bad feeling about a guy, high-risk occupation, had a high-risk event, go straight to an EP study. Okay, so going back to our young lady who has recurrent syncope, hasn't injured herself, has a prodrome, has a positive tilt table, her physical exam is normal, her diagnosis is reflex syncope. In and of itself, not an interesting diagnosis, but a very interesting patient because she's the one that you really want to help. She's going to lose her job because of this problem. It's clearly affecting her quality of life. We're going to do a slight detour before we get back to her, and I think this may be a little more legible in your syllabus. But these are just a couple slides to show you in what studies have been done in meta-analysis what the most likely diagnosis was, stratified both by the presenting setting, whether that's your clinic or the emergency room or a syncope unit, and on the next slide, stratified by age. In almost every category, reflex syncope is the most likely diagnosis, even in the elderly. But I have that there for your reference. So focusing on this young lady, in general, neurally mediated syncope, these are the things that we think about trying. We may think about pacemakers, certainly not first and foremost. We may think about beta blockers. As I mentioned, we don't do that much anymore. But we will think about vasoconstrictors. There is some very minor data on SSRIs. But first and foremost are the bottom two: isometric physical counterpressure maneuvers and reassurance and education. People with reflex syncope will not kill them unless they're doing a high-risk activity while they syncope. So if, say, you're skydiving and you lose consciousness, you will probably die. If you're driving a car and you syncopize, you may or may not die. But syncope in and of itself, this is not a lethal arrhythmia, this is not VT, this won't kill you, and that does provide a lot of reassurance for patients. This are adapted from the ESC, that's the European Society of Cardiology guidelines, which documents that reassurance and education and isometric physical counterpressure maneuvers are the best treatment. I think the other interesting thing about this slide is it does tell you a little bit about when pacemakers are indicated, and as I alluded to, those are the people with a cardioinhibitory response, the people that have sinus pauses, people you tilt table them and they get very bradycardic. Those are the people where we might think of a pacemaker, but we're certainly not going to rush to commit them to a box. So we tried her on all those things, and we tried them all at the same time over the course of 6 months in repeated clinic visits. We gave her fludrocortisone, we gave her midodrine, we gave her salt tablets, we gave her compression stockings, and we couldn't help her. I finally read the ESC guidelines and I said, boy, we should try isometric physical counterpressure maneuvers, and believe it or not, she got better. Unfortunately, I left my fellowship before I could see if she was able to keep her job, but I do know that she had less frequent episodes, more like 1 a week compared to 4 or 5 a week. So it's not perfect, but it's better. And it also makes your patients feel better knowing that they can do something that will abort their syncope 57% of the time in one trial. So physical counterpressure maneuvers, it's basically what you see here. It's tightening the muscles in an isometric fashion anywhere from your arms to your hands or below the belly. And the idea is to increase venous return in a bolus fashion to the right ventricle to increase preload. Squatting can also help. And you would be surprised how many people can abort syncope with these maneuvers. A lot of times people come to me and say, you know, doc, it's really weird, but I squat and I don't lose consciousness, but if I'm driving or if I'm somewhere where I can't do that, I always go out. They just figure it out. Speaking of driving, this is another very common question for cardiologists, and I wish I had a better answer for you, but let's talk a little bit about it. Our job as cardiologists, or you as a primary care doc making a recommendation to drive, is really to assess the risk. Are they likely to syncopize while they're driving? Do they drive a lot? Do they have warning that'll keep them from losing consciousness or enough time to pull over in the car where they won't hurt themselves? What's the necessity of their driving? For those of you that know, I wasn't driving for the past 3 months because I fractured my pelvis in a bike accident. I can tell you it significantly impacted my life. It's very difficult for you to tell a patient, sorry, you can't drive. All of a sudden they got to find someone else to drive for them. They may lose their job. They may not be able to go to work. It's a big deal, and we take it kind of callously. We say, well, don't drive. I'll see you in a couple months. We'll see how you're doing. Not all patients can do that. And of course, you should know what your local state laws are. And this is an excerpt from our state law. Basically, in the first half of the description of law, it says every physician has a mandate to report a lapse of consciousness. In one study of California ET docs, this happened 18% of the time. So you can tell we're all breaking the law. But in the second half of the excerpt, it says, well, our goal is to guide reporting to identify the people where this is more likely to happen. So maybe we're not breaking the law, we're reinterpreting the law and saying, well, I don't think that's likely to happen to this patient, so I didn't report them. Although I think, me included, we're mostly just lazy because it's a really painful form to fill out. We do have some data to suggest maybe it's okay to let them drive. This is what I like to point at. There was one study, the largest study of syncope that's been done to date, almost 4,000 patients. 10% of the initial events that got the patients into the study had events while driving, and they were monitored for recurrence. Again, the most common cause was reflex syncope. Recurrence occurred less than 1% per year. So 7% over 8 years had a recurrence while driving, and they were all allowed to drive. There wasn't any recommendation for these patients not to drive. So the recommendations vary. If you read Brownwald says, well, tell them not to drive for 3 months, do your workup if you're going to do one, and then make an assessment of their risk. That's great. I don't know that I would like that. Like I said, it's painful. Interestingly, European Society of Cardiology actually in their guidelines says you should realize that teens and elderly are a much higher event rate than 1% per year, so your syncopizers are the low-risk people. And if we let them drive, maybe we should let our syncopizers drive. I guess if you're a teenager who's syncopized or an old folk who's syncopized, maybe not. Just for a little bit of a break, we're going to come back to that first picture later, but this one is really an interesting one. It's a nice lady who just saw the bloodstained clothes of her husband and lost consciousness. This is an example where a picture is worth enough words and the story is good, and you could say, okay, I feel pretty confident that's probably vasovagal syncope, I'm not worried about her. But this is an example of where maybe the picture isn't so good. You may take a look at her and say, wow, this looks awful. There's a chair that's fallen over, she's hit the back of her head, she's lost consciousness, she's got her spaghetti on the ground, this is clearly cardiac or arrhythmogenic syncope, she needs a defibrillator, this is awful. I had a lady just like this who has made some form of berry pie once a week for most of her adult life. She's a very nice grandmother, and she was making blackberry pie and had been standing in the kitchen for an hour stirring a pot of blackberry juice or whatever goes into pie and lost consciousness. And I imagine that she ended up like this because she had an injury to the back of her head, the pot was on the ground, and it's just an awful story. You say, oh my God, we're really worried about her. But when you listen to the story, not focus on the end result, listen to the story. She had been on her feet for an hour, hadn't sat down, she's got venous pooling. She's got her face in a pot of bubbling juice. She's got steam hitting her face. She's going to vasodilate, and there will be a risk for loss of consciousness. She's not going to remember what happened. She's not going to be able to tell you that she had palpitations prior to the event because she hit her head. But that doesn't mean that it's arrhythmogenic or cardiac syncope, and it doesn't mean that she needs a $2 million workup. She's just someone who was in the kitchen who vasodilated and lost consciousness. So, how do you determine who are the people you worry about and who are the people you don't worry about? Things to worry about. Abnormal EKG, clearly. Something to worry about. I mentioned that any abnormality in EKG starts the cascade of increased mortality. Abnormal monitoring. There's evidence of an arrhythmia. There's evidence of a problem. Heart disease. An event while supine or with effort that takes you away from vasovagal or orthostatic syncope. Palpitations, and very certainly a family history of sudden cardiac death is worrisome. Anyone with a family history of sudden cardiac death should be evaluated by a cardiologist, and it should start with an echo and a very detailed family history. Things that are reassuring. Autonomic prodromes, clear precipitating factors, prolonged sitting, prolonged standing. A good story. We can all identify what's a good story. I was getting my blood drawn. I lost consciousness. Nobody worries about that patient except put the arm down next time you get your blood drawn. How do you manage them? Well, clearly it's by underlying cause. If they're hypoglycemic, fix their sugar. If their sodium's 155, fix that. If they have a cardiac cause, there may be medications, they may need a pacemaker, ICD. It all depends on the exact diagnosis. If they have seizures, send them to a neurologist. Please don't send them to me because I don't know what to do with them. In summary, you want to know first and foremost, is it syncope? Was there a transient loss of consciousness? Was it rapid onset? Was it short in duration? And was there spontaneous recovery? You've got to get a good history, your exam, much better than any test that I have. And remember that risk stratification is at least as equally important as a diagnosis, especially because I already pointed out it's so hard to reach a diagnosis in most of these patients. If you look back on the slide where I was showing you syncope units versus ED versus general population, you'll see a diagnosis was reached in syncope units still only 70, 80, 90% of the time. There's always going to be a fair number that never get a diagnosis. This is a very nice algorithm that I love. If you look at the right side, the two lowest boxes, low risk, single or rare event, no further evaluation. This is what I tell my patients. First offense is free. If there's nothing worrisome about them, 35-year-old female, 45-year-old male, normal EKG, you listen to them, no murmurs, no chest pain, no palpitations, they had an event, doesn't matter if it happened while driving. First offense is free, they don't need more evaluation. But use your best judgment. If you're worried about them, then you're going to evaluate them. This makes you feel better if you're not worried about them. Ask yourself, is further testing really necessary? Use physical counterpressure maneuvers. It has been studied and it is the best. And I'm sorry that 57% is the best, but it is. 57% is the best. Midodrine, fludrocortisone, compression stockings, not better than 57%. Use medical therapy for refractory cases. Echo if you're worried about structural heart disease. Monitoring if you're worried about arrhythmia. And please, by all means, send them to us if you're worried about them. We love seeing syncope. It's what we do. Just to talk very briefly on bradycardia as we're winding down, how cardiologists think about bradycardia. I get a lot of consults for symptomatic bradycardia, maybe loss of consciousness, dizziness. First thing that I do is determine, do they have symptoms when they're not bradycardic? Easiest way to do that, make them walk in your clinic. We have 2 flights of stairs outside our clinic. If I get a consult for symptomatic bradycardia, I have them run up and down the stairs. If I get their heart rate to 80 and they're still dizzy, it's not symptomatic bradycardia because you just lost a bradycardia component. I love doing that. They do that in the emergency room a lot. I also look for reversible causes of bradycardia. This is more bridging to, we're getting consulted for a pacemaker. I can't put a pacemaker in someone who's got a reversible cause of bradycardia because I'm not doing my job. That's malpractice. So if they're septic, if they're hypoxic, if there's clear hypervagatonia, bradycardia in the setting of nausea, vomiting, things like that, if they have medications that are non-essential, then I'll take those medications off before I put a pacemaker in them. On the other hand, if they need a pacemaker and they have clear symptomatic bradycardia, we're happy to do it. I don't want to be like my guy in Alamogordo in southern New Mexico who generated $2 million of revenue by putting all his patients on beta blockers, saying that it was essential therapy for something, and then put pacemakers in all of them because he's not practicing anymore. Okay, any interesting ideas as to what's going on here? Corset's too tight, that's a good one. Anyone else? Someone's got to have an idea. Playing cards, I like the playing cards, that's important. I don't have any evidence of pregnancy in the picture, but I didn't hear that one. She got a bad hand, and she faked syncope, knocked over the table. That's her purse on the left side of the screen, so that she could get out a bad hand at poker. This was painted in the 18th century. I thought it was hilarious. So you always got to be on the lookout for that too. People that are faking syncope to get out of a bad poker hand. Any questions? I'd also be happy to take any questions on the things that Dr. Coleman was talking about with hypertension and lipids. I know Andy Cohen and I were talking about it, and that seems to be a hot topic. Angus.
Can I ask a question about, I have a lot of orthostatic or syncope or syncope from my hypertensive patients
Sure.
who are still pretty hypertensive, but then every once in a while get pre-syncopal, syncopal. How do you approach that in that patient who is still hypertensive and yet still symptomatic sometimes?
Yeah, those are a very difficult class of patients, and obviously a blood pressure of 90 is more worrisome than a blood pressure of 190 in someone who's going to lose consciousness. So I'm always limited by the lowest blood pressure. Usually what I'll try to do is determine what are the settings in which they're hypertensive, what are the settings in which they're hypotensive. So a classic patient is a dialysis patient. I might only give them amlodipine or Coreg on non-dialysis days. That's very common. If they're only hypertensive at certain times of the day, I will smooth out their medications. So even the once-a-day drugs like losartan or lisinopril, I'll split BID, or amlodipine, I'll split BID. But they're very challenging. And you want to know, are they hypotensive because they're dehydrated, or in the most worrisome case, is it due to an autonomic nervous system problem? And if it's an autonomic nervous system problem, they're diabetic, they got neuropathy, you're really in a hole because you can only go by the lowest blood pressure, and it's safer to leave them hypertensive. Other questions? Well, thank you all for staying to the end. I really appreciate your attention.